add on azathioprine or something along with it. Cyclophosphamide, the standard schedule which is available, which we have taken mostly from the rheumatologist, because whatever we are doing, the immunosuppressive therapy, we are taking over the schedules from rheumatologists and other immunologists. We are giving only a single pulse. They are generally giving one pulse every month. The exact dosage you can check up, but we are generally giving a single pulse followed by steroid. You can add on 2-dose pulse steroid along with it, and followed up with 1 to 2 milligram per kg body weight of oral steroids, plus we added azathioprine in this patient along with it. And we are, with this full dose of azathioprine and a low dose of steroid, we are able to maintain this patient in remission and 6-12 vision for now at least more than a year or so. But that is the problem. 1 year is too short. For us, for a presentation, it might look quite good. For the patient, these patients do require very, very long-term therapy, and that is a point of concern. Another patient, here you see patient of posterior uveitis, he must have had multiple attacks. This patient is at present in remission, but again because he is on some immunosuppressive. So again, my choice of immunosuppressive is generally azathioprine. So he is again on azathioprine and a low dose steroid. If I again stop him, I do not want to, because the lesions are quite close to the fovea and I cannot afford to have another attack. Right now, again, these pigmentary changes and the changes in the choroid do make the fundus look bad, but these patients somehow do have sometimes good vision. Again, this patient would have around 6-12 vision. But another attack, repeated attacks, would definitely cause fallen vision, which may not be recoverable. So again, if the patient is, we are able to maintain him on remission on these drugs and keep monitoring the blood parameters, which Dr. Muralidhar will be talking about, then I think it is quite beneficial for them. This is a wide field optos image of a patient again of chronic VKH. You can see these sort of Dahlen-Fook nodules, or some of them are just RP, hypopigmentation, again in remission. A sunset glow is there. These nodules are all signs of healed disease. This is a young girl, about 13 years of age. But again, we are able to maintain her 6/9, 6/12 vision because she's on methotrexate. Otherwise, she would have thrown repeated attacks and the fovea and the disc would have gotten involved multiple times and the patient would have subsequently lost vision. And younger patients do quite well on methotrexate. They tolerate it better. Even at a higher dose, we can give it to them and for a longer time. But unfortunately, in the left eye, she's developed a secondary complication here. She's developed a choroidal neovascular membrane. So even when your patients are in suppression, in remission, you have to keep a lookout for secondary complications. And for this, we had to give her Avastin. We have given her twice for over a period of 6 months, which has responded and she's stable. But yes, Avastin is not a final treatment. She might require the treatment again. So we have to keep monitoring her with the OCT and her visual symptoms. Another patient I want to show you, who came to us with again blurring of vision and some cells in the anterior chamber. When you look at the fundus, you can see the folds, you can see the blurred disc margin, you can see a lesion here in the choroid. You do an angiogram, you can see the leakage into that lesion and some pinpoint leaks with the hot disc and some diffuse leakage. Looking at this, initial impression was VKH. So probably VKH also has a lot of variation in presentation from a very mild to a very severe disease. Again, we start the patient on steroids, taper it very, very slowly. I kept this patient on steroids almost for say about 8 months. I would taper them very slowly once I am down to 20, not every week. If you taper them every week, you are going to get a relapse very fast. So after you have come down to 20, make it 17.5, make it 15, make it 12.5, increase the duration, give it 12.5 for a month, 10 milligram for 4 months. Do not be in a very much hurry to taper it down. Despite that, once I was below 10 milligram, the older lesions are healed, but the patient comes back with these fresh lesions. So despite giving a very long-term steroid therapy, despite tapering it very slowly, the patient at present is asymptomatic because the fovea and disc appear normal. But when I dilate and see the fundus, I can see new crops. These are not very typical of VKH, so the patient actually may not be VKH. We did a CT chest also, but we couldn't find anything. But maybe because we already treated the patient with so much of steroid, patient might as well be a case of sarcoidosis. So the other eye also showed a new patch, and the previous lesion you can see has pigmentary changes and healed. But now again my dilemma, should I pump the patient again with so much steroid? So no, since the disc and macula are okay, I don't want to give a high dose steroid at this level. Probably just a 20 milligram would suffice, but I add an immunosuppressant to take care of the subsequent relapses. Now another patient who has had these multifocal choroiditis and multiple lesions, one macula is already significantly disturbed, so this patient is probably a one-eyed patient. But when I look at the other eye carefully, I can see an active patch developing here. Now this is a one-eyed patient. Again, I cannot afford repeated attacks in such a patient, and I cannot afford giving them steroids 2 to 3 times a year with high doses. So such a patient, I would again start on some kind of immunosuppression. This is a specific indication, sympathetic ophthalmia. Most of the patients of sympathetic ophthalmia, one eye you'll see some trauma or some surgery, and the other eye the patient will come up with disc edema and some exudative detachment and some folds and some cells in the anterior chamber. And again the angiogram will reveal the hot disc. Your OCT will start showing fluid under the retina. Your OCT will also reveal the posterior vitreous cells. Now this condition is chronic. It is many times people do believe that such patients do require a lifetime of immunosuppression. So, but in our experience, this case has a subtle attack and we caught it quite early. Macula is not that disturbed, vision is good. We just gave a pulse dexamethasone therapy to the patient, and the patient has settled down quite well with good recovery of vision. Now this patient I will try to taper slowly on steroids and maybe try to maintain on a low dose steroid. But yes, despite that, if I get relapses, then again this patient is a good candidate to go on for immunosuppression. So few conditions like VKH, sympathetic ophthalmia and Behçet's disease have been also mentioned by many authors as even primary indications for immunosuppression. You don't have to think much. Once you have started steroids, you can also simultaneously start immunosuppression. But in our experience, patients do behave, they have a spectrum. So minor cases of sympathetic ophthalmia, we have tried to maintain on low dose steroid also. Now another patient here next to the fovea, you are seeing a patch of choroiditis, and in such patches, patients, the history of pain on ocular movement was also specifically there, and ultrasound confirms this fluid in the subtenon space forming a sort of partial T sign here. So we would call this more as a posterior scleritis. We give him steroids, the lesions start healing, but the active border is still there. This will also heal when the patient continues his steroid therapy, but again you see the lesion being close to the fovea. I again cannot afford another recurrence in this patient. It will knock down the patient's fovea. So this patient also, along with steroids, once they are being tapered, I will start on immunosuppression. This is a kid of sympathetic ophthalmia who has developed this Cushingoid facies because of repeated steroid therapy. Again, this is not a outcome which I want to see. Much before that, I would like to see such a patient shifted on immunosuppressive therapy along with steroids. Another patient with multiple lesions here, and this is again a chronic case. You can see old healed scars, some hard exudates along with the disc edema. Angiography again revealing the disc leak with the pinpoint leakage and some hypolucencies in the choroid suggestive of active infiltration there. Again falls into the spectrum of VKH or multifocal choroiditis. But again the fovea of this patient is healthy. Patient has 6/6 vision. Only complaint is mild eye pain and mild disturbance in vision. This patient responds well to oral steroids, and he is maintaining this on just a 5 milligram dosage of steroid. Such a patient probably I will not shift on immunosuppressants. If you can maintain a patient on less than 10 milligram steroids in remission for a long time with good vision, probably there is no need to go on for immunosuppression and with all the monitoring that immunosuppression requires. So this is again a 6 month later photograph just on steroids, very low dose, he's quite stable. So we would probably just maintain him on steroids. So just looking at some of these cases, when do I start immunosuppressive? So number one, it depends on the primary diagnosis. Like I said, some conditions like VKH, sympathetic ophthalmia, Behçet's disease, chronic pars planitis, scleritis, these do fall in the indication where you can even start immunosuppression at first presentation as a primary therapy. Otherwise, it also depends on the proximity to the fovea and the severity of the disease. Mild cases, you can also just monitor on steroids and bilaterality of disease. And most important is the interval of recurrences. If the interval of recurrences is less, that means once you stop the steroids, the patient goes into a relapse quite fast, then I do not want him, that means the disease is steroid dependent, then I don't want him to have all those side effects of steroid. I would like to start the immunosuppression. And sometimes we have seen, we treat uveitis choroiditis with steroids and the patient comes back with a CSR. That becomes a little difficult and tricky situation to handle, but probably the only solution is that we have to taper down the steroids as fast as we can, but to maintain the remission we add on an immunosuppressive drug. So when only to use steroids, if you are able to maintain long-term remission without medication, good enough, or even with steroid, as what Stephen Ryan quotes, if less than 10 milligram, you can maintain a patient on remission for longer than 4 months. Or when treating children, he would like to shift to immunosuppressants. But if you can maintain remission less than 10 milligram of dose of steroid for more than 4 months or so, Stephen Ryan recommends that probably we could just continue with the steroid treatment and not shift over to immunosuppressants. Or if your patient is not likely to monitor and the blood tests and get them routinely done, then it is a little risky to shift your patient onto immunosuppressants. But there are some newer concepts coming onto this. There is a recent article by Professor Foster et al. Recently in January 2016. Now what they are saying is that they believe that long-term remission occurs only when there is a resetting of the immune system, and they believe that this is possible due to only if you are able to maintain a corticosteroid free remission using these immunomodulatory agents for about 2 to 3 years. So they are a little more aggressive. They want to maintain a steroid free remission. So that means they would have to use more of immunosuppression, maybe even more than one agent and at a significantly higher doses. But they do this because their belief is that if a patient is having steroid free remission, only then you can tell whether you are pumping him with adequate immunosuppression to reset his immune system. And that is probably something which all us UVI specialists would look at, a cure to the disease. So if there is somehow the immune system is reset, even if it takes 3 years and after that patient is not going to get subsequent attacks, it might be a good idea. But these are newer concepts. Even we are at RP Center not yet following this, but I think these things do need to be looked into in the future. Thank you. Thank you very much.